Welcome back to the second presentation in GI. Our focus here is the lower GI. Here we'll focus on some issues in lower GI and wrap up things that we didn't cover in the first GI block. We're going to specifically talk about some of the bowel-specific anti-inflammatory regimens that are used for either Crohn's or ulcerative colitis or irritable bowel syndrome. We'll talk a bit about laxatives and antidiarrheals. So as we think about the clinical features of inflammatory bowel disease, one first thing to differentiate is ulcerative colitis from Crohn's disease. And what is really different is Crohn's disease could occur anywhere in the GI tract, from the mouth all the way to the anus, whereas ulcerative colitis is really confined to the rectum and the colon. Perhaps sometimes the terminal ileum involvement as well. And typically, we generally consider Crohn's as more severe in general, with the lesions being deeper as well. Both of them, though, both of these will have similar therapeutic regimens that are used, but it's more likely that the more aggressive regimens are going to be used in the management of Crohn's disease. The severity of ulcerative colitis is also considered based on frequency of stooling and whether or not there is blood with that stooling and other symptoms, including often elevated heart rate, elevated sed rates, and the requirement or not of transfusion. Crohn's disease severity is also listed here as mild to moderate, moderate to severe, or severe to fulminant. And typically what we'll try to do is to manage particularly mild to moderate disease as possible with oral therapies. But when the more moderate to severe cases, typically we're going to have to use the more aggressive disease-modifying regimens as well. So the first oral agents that are used for inflammatory bowel disease are the aminosalicylates. The first of these on the market, or the prototype agent, was sulfacetamide, and this has been around for a number of decades. Sulfacetamide is cleaved by colonic bacteria, and really there are two components. There's the aminosalicylate, which is anti-inflammatory, and then there's a sulfa component, which may or may not be considered inactive. Whether or not the sulfa component has some antibacterial effects that have some benefit or not is not always clear. Typically pretty well tolerated agents overall, but folks will have some GI disturbance pretty commonly with it. Occasionally folks would have arthralgias. If they have any sulfa allergy, then these would be avoided. They would particularly worry about, in those cases, a more severe hyperimmune response associated with that. So we would avoid the sulfasalazine with folks with a sulfur allergy. Typically, we give a pretty good dose of these agents. Usually, sulfasalazine is dosed at 4 to 6 grams a day for induction, and then for maintenance, 2 to 4 grams a day. There are lots of different formulations that are available, immediate release and enteric-coated products, and we look at titrating these over a couple of weeks to get to the optimal therapy for a patient that they can tolerate. The related agents for aminosalicylates, the ones that are more commonly used, that don't contain sulfur and are better tolerated than sulfasalazine, are mesalamine primarily. Alsalazine is available as well. And mesalamine has a number of different formulations, and what's interesting is that the mesalamine formulations are specifically targeted for release at a particular section in the bowel. And so they are not interchangeable. And most gastroenterologists, after they evaluate by colonoscopy, for example, of the sites or regions of inflammation, if they're going to go with mesalamine, they often will pick a product that is intended to be delivered at the site of the greatest degree of inflammation. So there's mesalamine as a rectal enema, which would only affect the rectum and the terminal colon. There are other delayed release components or brands of these products that are targeting either the rectum or the or as early as the distal ileum and colon, for example, for Asacol HD. So these products are really chosen for their site of action. We also can sometimes use corticosteroids for acute flares. We try not to maintain folks on these, but unfortunately, a lot of folks will have to be on corticosteroids for their inflammable bowel disease longer term. And classically, we've historically used prednisone, but the reason we'll use budesonide and what the advantage of budesonide is budesonide isn't absorbed orally. And so we see much less HPA, hypothalamic pituitary adrenal axis suppression associated with budesonide. And so budesonide, or the brand name Entocort, really has an advantage for folks with moderate disease whose disease is really limited to the colon or to the lumen. And so many clinicians would look at that as an alternative and be a bit more sparing on any suppression of the hypothalamus pituitary axis. Not saying that won't happen, but the effects are considered it's considered a better or more appropriate agent with less adverse effects. We could also use a rectal enema, corticosteroid enema, not very commonly used, but when it is used, it would be considered an appropriate choice when the lesions are at the rectum or very distal in the colon. The other things that we'll see sometimes used in conjunction with inflammatory bowel disease as adjunctive therapy are antidiarrheal preparations. We'll talk a little bit more about these later in this block. And the most common one is probably Imodium or loperamide. We could also use agents that are antimuscarinic in property, and so they reduce spasms in the colon. In the lower GI tract, we see Bentyl used, probanthine, or Levsin. And sometimes we'll see cholestyramine, which is an older agent that's a bile acid sequestrant. It will sometimes be helpful in a subset of patients after ileal resection, for example, to reduce diarrhea associated with that secondary to excessive bile salt response for that diarrhea, but not very commonly used, but sometimes used. Then we go to the immunomodulators. The immunomodulators, like we talked about in dermatology and like we'll talk about later in the year in rheumatoid arthritis, these agents are effective for moderating the inflammation associated with Crohn's specifically, but also ulcerative colitis as well. The older agents that are less specific are 6-mercaptopurine, azathioprine, or methotrexate. And these agents have been used for a number of decades. They're unfortunately associated with a fair amount of adverse effects, as you would expect, because they're more aggressive regimens. The second generation immunomodulators are monoclonal antibodies directed against often tumor necrosis factor or some other factor. And probably the one we see most often, the two we see most often used are infliximab or Remicade, and Tysabri is pretty commonly used now as well. But you'll still see other agents in this class used, any of the other monoclonal antibodies. So let's first spend a minute talking about infliximab or Remicade. This has been around for more than a decade. It's a chimeric monoclonal antibody against tumor necrosis factor. It's indicated for both Crohn's disease and ulcerative colitis when it's moderate to severe. It's typically dosed as an IV loading dose and then every 2 to 6 weeks or 8 weeks regimens. It's sort of you start with week 0, week 2, week 6, and then every 8 weeks a regimen associated with ongoing therapy. But we worry about patients who are on these therapies for a number of adverse effects, both immediate or during the infusion or shortly after the infusion, but also long-term as well. So as a clinician, if you're working in primary care, for example, you may not be giving these, you may not be ordering these, but you need to be aware that your patient is on these because that will impact a lot of things. So the acute reactions we often see are infusion-related reactions. Patients may have a hypersensitivity reaction, or they may have hypotension, fever, urticaria, pruritus. And we try to infuse this in the infusion suite, and typically these are given, folks come into the infusion suite and usually in the outpatient section of a hospital. Sometimes that's the same suite where they give chemotherapy, and it's given over 2 or more hours. We typically will dose Tylenol and usually Benadryl or diphenhydramine with it to reduce these infusion-related reactions. But they may also have a reaction that happens up to a week to 10 days after their infliximab therapy, a delayed reaction, and as a clinician you need to be kind of aware of that. Probably the biggest concerns we have, though, are the next set of problems associated with these agents longer term. Because they are immunosuppressant, we worry always about infection. So consider folks who are on these therapies as immunosuppressed, and so as such, we need to worry about anything that indicates they could have an infection, anything as simple as a urinary tract infection to pneumonias, septicemias, meningitis, anything. So we're aware of that as a risk associated with these therapies. That could be risk for tuberculosis, so we rule out TB before we start, and even periodically during therapy if their exposure to TB is there or risk for TB development is there. We worry about fungal infections and overwhelming sepsis, and we would hold off on giving another dose in a patient who looked like they could have an active infection. We rule out TB, as we alluded to. Many of these monoclonal antibodies also can exacerbate heart failure. So we're very careful about giving them to any patient with heart failure, and by the time we get to New York Heart Association Class 3 or 4, they're considered contraindicated for use. We also look at carefully dosing them so we don't exceed a dose that increases the risk for developing heart failure. We also see in a number of patients that ongoing therapy will result in antibody induction, particularly anti-nuclear antibodies, and so that sometimes presents as what looks like a lupus-like syndrome or something like that. Most of the time that's asymptomatic and doesn't really mean much, but if you're working somebody up for rheumatoid arthritis or for lupus, and in fact they may be on this therapy for rheumatoid arthritis because of its efficacy there, you just want to look at that marker for anti-nuclear antibodies may be affected just by the therapy itself, and so that becomes a less useful diagnostic. Bone marrow suppression, as we alluded to already, for infection risk, but you could also see a pancytopenia, so you want to watch out for that. And you also worry about activation of any hepatitis, particularly hepatitis B, but any hepatitis or any other infectious disease you worry about. We also sometimes see vasculitis as a problem with some of these agents as well, so you want to keep an eye out for that. Lastly, because of their immunosuppressive nature, there is an increased risk for lymphomas associated with these agents, and so we're careful about weighing the risk and the benefit of that. And anytime we do anything that suppresses the immune response, unfortunately we can't just be targeted to the immune response associated with the inflammatory bowel or the ulcerative colitis or Crohn's disease. We unfortunately can really affect the immune response that affects cancer risk. So we need to pay attention to that as well. So some of the other monoclonal antibodies are similar, and they're listed here. So Humira, Cimzia, and Tisabri are three of the other agents that are pretty commonly used as monoclonal antibodies. And Tisabri in particular, I think, is an agent that we see increasing use in the last couple of years in infusion suites in hospitals. All right, let's move on to laxatives. We have a fair number of patients who will be on laxative therapy or need laxatives. This is going to be particularly useful in folks who have constipation. And when we talk later on in the year about pain management with opioids, we absolutely will be giving laxatives concurrent with opioids for pain management, just to reduce the risk for significant constipation or risk for impaction. Laxatives are used to ease or stimulate defecation. There are different classes of laxatives that are available, and so we'll use them in different ways. But our goal may be just to soften the stool, or it may be to increase the motility in the colon as well. And the effects may have an onset and duration of action that is very short, or they may have one that is that is more prolonged over a couple of day or two. And when we use the term catharsis or cathartic, that occurs, that's like an aggressive laxative that is going to promptly evacuate the bowel. And we consider cathartics those agents we use, for example, for a bowel prep when you're trying to prepare somebody for a colonoscopy, for example. So the first thing we think about before we start laxatives are any of the therapies that the patient is on causing constipation. And the worst of these are the opioids. The opioids are notorious for causing constipation. And I can't tell you how often we see in clinical practice folks who come in who are impacted, which is very distressful for patients. And it requires aggressive management to correct. So we pay attention to that with opioids. But anything else listed on here could be contributory, specifically antimuscarinics or things that have anticholinergic properties, like some of the antihistamines, some of the calcium channel blockers associated with that. Certainly calcium and iron salts are associated with constipation, and the tricyclic antidepressants because they're antimuscarinic as well. So things to think about before we start laxative use, first of all, is the colon functioning. And what is the function of the colon? To absorb water, electrolytes, doesn't say a lot of nutrients, but it really sort of equilibrates water bowel function. And we're going to sort of look at some of our modalities that are going to try to address or fine-tune that. Typically, dietary fiber is necessary. It facilitates stool by the absorption of water into the colon and also is digested by colonic bacteria to increase fecal mass. And we typically look at most patients need dietary fiber up to 60 grams a day. And we consider constipation as when the person's stooling is not consistent with their baseline. And this is somewhat individual, but we determine it compared to baseline based on both the hardness of the stool and the frequency of stool. The hardness of the stool is particularly important. And we look at what those factors are. Is it lack of exercise? Is it diet? Is it meds that are constipating? And what we typically recommend for otherwise healthy folks is the first choice for managing constipation is increased dietary fiber and moderate exercise. And those two things are our first steps for folks who are otherwise reasonably healthy. The indication for laxative use is when folks have a hard stool, if that hard stool leads to straining or leads to painful elimination, or if they have exacerbation of hemorrhoids, then that's a reason to consider a laxative use. It's also helpful for folks who don't want to strain at stool. For example, if they have angina or cardiovascular disorders, many older patients also, you don't want them to overly strain. And folks with hemorrhoids, certainly hard stools or constipation can make hemorrhoids worse. Typically, when you're looking at using a laxative, we may also have other reasons. For example, you may have to get a stool sample, or more commonly in practice, if you're going in for a diagnostic colonoscopy of some sort, then you need the prep that cleans out the bowel to do that. And typically we're going to use a regimen that is over probably 6 to 12 hours, really going to clean out the colon without disrupting, hopefully, too much electrolyte balance. Reasons why you would not want to use a laxative. If you've got folks with undiagnosed abdominal pain, nausea, cramps that consistent with either appendicitis, or have some kind of a surgical abdomen, or have an obstruction of some sort, particularly someone who has, like, for example, a cancer risk with a mass, then the laxative, particularly a stimulant laxative, would be problematic in that you are increasing colonic lumen pressure for which there is no passage of that stool because of that obstruction. And so you want to be really careful about evaluating that. And sometimes you can get that bowel obstruction assessed by a KUB or an X-ray if there's some question that that's an issue. There are a number of different classifications for laxatives, and we'll talk about these, whether it's an osmotic or a saline osmotic laxative, bulk forming, a surfactant, or a stimulant laxative. And we'll talk a bit about each of these classes. First of all, polyethylene glycol, or Miralax, is probably the most common laxative we see used now, first-line therapy. And it's an osmotic laxative. Polyethylene glycol is very well tolerated in a great number of folks with reasonably good endpoints. Doesn't cause a lot of distress for patients. It's relatively easy for patients to take. It's reasonably palatable. And so this, in lower doses, we'll use polyethylene glycol as a daily laxative. In higher doses, much higher doses, we'll use this as the basis of a bowel prep for bowel evacuation. And so typically the dosage difference is a daily dose of Miralax. Typically we'll look at maybe 8 or 16 times the dose of the daily dose when we use it as a cathartic for bowel evacuation. Another osmotic diuretic that is used on occasion as a laxative, probably more often in hepatic failure for hepatic encephalopathy, is lactulose. It's a semisynthetic disaccharide. It's poorly absorbed orally, and what it will do is allow the resident bacteria to metabolize lactulose to lactic, formic, and acetic acids that have a mild osmotic action. It also enhances the intestinal excretion of sodium by altering the pH and allowing the ammonia to migrate into the colon and then become ionized in the colon, so it stays and is trapped there and expelled on fecal elimination. Another osmotic diuretic that is sometimes used as a glycerin suppository, not nearly as commonly as we used it a few decades ago. The glycerin suppository applied rectally often will serve to stimulate rectal contraction, and you might see an evacuation in 30 minutes or so. It's considered fairly mild, but it's probably just the rectal stimulation itself that's more likely to induce stooling than the glycerin itself being all that effective. There are also some saline osmotic laxatives. These are more potent or strong in their nature. One is citrate of magnesia. Second is magnesium hydroxide. Also, there's a sodium phosphate formulation that's sometimes used as well. These are poorly absorbed salts that have osmotic action, drawing fluid into the intestinal lumen. They also will serve to stretch the intestinal wall. They stimulate peristalsis, therefore, and you begin to see an effect in a few hours for higher doses, and within 6 to 12 hours for lower doses. The citrate of magnesia, or magnesium citrate particularly, can have its onset of action in just a couple of hours or even less, and sometimes citrate of mag is used as a cathartic as part of a bowel cleansing regimen. But for some folks, it's considered moderately harsh in nature. Magnesium hydroxide also works pretty aggressively. It's also known as milk of magnesia, and we alluded last week to magnesium hydroxide also serving as an antacid with a fair amount of laxative properties. The thing with these agents we need to worry about is a change in electrolyte balance, particularly with the sodium phosphate in patients who have renal insufficiency particularly. We also see commonly used bulk forming laxatives. These have actions that are similar to dietary fiber. They're either natural or semi-synthetic polysaccharides or celluloses, have an action usually within 24 hours up to 72 hours, and they work the same as dietary fiber will. They will increase fecal mass, they will cause peristalsis, and they actually will, in a sense, regulate the fluid volume in the colon. And so sometimes these bulk forming fiber laxatives in particular actually can equilibrate fluid, and we actually see these agents used also in some cases for folks who have a diarrhea, in the sense that they will equilibrate and absorb some of the excessive fluid in the colon as well. So they can be used primarily as laxatives, but sometimes as antidiarrheals as well. They're indicated for temporary relief of constipation and sometimes for irritable bowel syndrome. Their adverse effects are really minimal, although they may help. They may affect absorption of other drugs if they bind to them. And the most common of these is probably psyllium or Metamucil. Also, methyl cellulose and polycarboxyl are other examples of more synthetic bulk-forming laxatives. Typically, they're put into a slurry with a full glass of water or juice. There are also surfactant laxatives. Most commonly here is Docusate or Docusate sodium, which is brand name of Colase. And they work to soften stools. They do nothing for peristalsis, but they will, if you've got a very hard stool, adding Docusate to the regimen will help soften the stool and make that stool easier to pass. So folks who have very hard stools but normal peristalsis, just Docusate may be a good answer for them. We also have stimulant laxatives, and they have an effect on both stimulating motility, and they can also affect the water and electrolyte balance in the intestine. And they're widely used and abused, and the two real common ones here are bisacodyl or Dulcolax that's available either as an oral form or as a suppository form. And those are considered by many a part of a regimen when you've got day 2 or day 3 without a bowel movement. You may consider the use of a bisacodyl suppository, for example. More commonly we use now are senna extracts, anthraquilones, which are used as a milder stimulant laxative, if I can say that, and we see senna laxatives used commonly for patients on opioids. Probably the most common regimen that we see for folks who are on opioids to stimulate stooling and really help keep things in check is the combination of senna and Docusate. So a combination of a stimulant laxative with a stool softener. And that's pretty commonly used. Probably in our practice, I see that probably more often than any other laxative combination for folks who are on opioids. There are some historical stimulant laxatives that aren't used anymore. One is phenolphthalein, used to be by the brand name of X-Lax, but it really has fallen out of favor, partly because it's associated with carcinogenic nature in at least lab animals, and it's no longer available typically over the counter. And an older agent that was also a stimulant laxative used in days gone by, castor oil, which is considered relatively irritating, and as such, really we have better choices now than castor oil. Finally, as a laxative, mineral oil, and I would advocate against the use of mineral oil, particularly against oral mineral oil. There really will do, the benefit of mineral oil is that it will help keep the stool sort of in an environment that it could pass more easily because of the lubrication. But oral mineral oil has two major problems with it. One, it may affect the absorption of fat-soluble vitamins, and so that's not really a great thing to do. But the biggest risk for this is the risk for aspiration. And aspiration pneumonitis in a patient who takes oral mineral oil would be a problem. So we never use mineral oil orally anymore. The only mineral oil that we occasionally see used is an ingredient in an enema formulation given rectally for folks who have a very hard stool and difficulty passing stool. The mineral oil containing enema may make it easy to lubricate and passage of that stool on a one-time singular basis. All right, so here is a review again of all the agents for constipation. Nice set of tables here from the pharmacotherapy prep course that I've used this organization's slides, decks listed here. You see them throughout our presentations, and they do a really great job of summarizing data. So the saline osmotic diuretics listed here, like citrate of magnesium, magnesium hydroxide, milk of magnesia, they often have an initial early fast onset. We avoid them in renal impairment. We don't use them daily, but we use them periodically when we need to. Of the osmotic diuretics, probably polyethylene glycol is the one you'll see used most often. It's used for both acute and chronic constipation. It's effective and safe in most patients, well tolerated. It's really our go-to first-line drug for a patient who has chronic constipation. We see the stimulant laxative bisacodyl and more commonly senna, particularly senna when we look for folks who have opioid-induced constipation, really very commonly used for that for prevention in combination usually with docusate. Of the bulk-forming laxatives, probably psyllium, as long as someone doesn't have an allergic reaction to it, is pretty commonly used, sometimes causes some gas or bloating in patients, so you want to be aware of that. But otherwise, psyllium or metamucil, pretty commonly used. And until the advent of polyethylene glycol or Miralax, the psyllium was the first-line agent. The other advantage of psyllium is that it binds bile salts a bit and can actually serve to minimally lower cholesterol levels for patients. So that has an advantage of that. It doesn't do it by a lot, but the natural fiber really is effective for a number of folks for reducing the cholesterol a bit. Of the other agents here, the stool softener, docusate, or Colase is pretty common when you have a hard stool that needs softening. Pretty effective and usually uses in combination with senna, as we alluded to earlier. And the remaining agents here, we didn't really talk about much. One is Relistor, an FDA-approved agent for opioid-induced constipation. Another one, a couple of listed here, are approved for opioid-induced constipation. And I will say that while they may make some sense, these are agents that don't have a widespread use, that the ongoing safety and efficacy of these agents is still to be sort of determined. In my mind, at least, even though they are FDA approved, they'd really be considered second-line agents, and we don't see them used very much. In addition, these agents will probably end up requiring prior authorization if you prescribe them. And one of the last agents we'll talk about for irritable bowel syndrome with constipation is Linesse, which we didn't really talk about otherwise, and it's pretty much going to be under the purview of a gastroenterologist ordering this. As a primary care person, you probably wouldn't be ordering this agent. Generally pretty well tolerated, but sometimes you can overdo it and get diarrhea, and so you may have to titrate that. It's also contraindicated in patients with any type of mechanical obstruction, and we avoid it in anyone younger than 18 years of age. One of the things with laxatives that we need to think about is the potential for abuse, particularly folks who get overly aware of their bowels and need the frequency more frequently than they really need. We also see them used as abused in patients who have bulimia or body image issues to, in a sense, lose weight. And so we want to be aware of that. The problems with that, particularly with stimulant laxative abuse, is that over time you have a reduction in the nerve response to defecation. And so you want to be aware of that, as well as electrolyte changes, dehydration, and colitis. The treatment of folks who are abusing laxatives is to work with them to try to break that habit, to use maybe a higher fiber in their diet and moderate exercise if they're amenable to that. The other issue is that if there is a mental health component to this, that you're addressing the underlying mental health issue that the patient has as part of their laxative abuse process. I want to switch gears now and talk about antidiarrheals. And diarrhea pretty common in our culture, of course. It could be infection, it could be maldigestion, inflammation, or stress. And there could also be functional disorders of the bowel as well. And the complications of diarrhea include dehydration and electrolyte depletion. Our management typically involves first diagnosing, is it infectious, what's the etiology of it, and addressing that, replacing fluid and electrolytes, and providing relief of cramping and reducing the number of unformed stools that are passed. we can look at opioids and non-opioids, um, and then specific or non-specific agents. Let's talk about some of the options that are available as antidiarrheal. So before we actually start looking at that, like we did earlier, let's look at the drugs that can cause diarrhea. Certainly antibiotics can do that. And so sometimes the addition of a probiotic can help there, sometimes not. You worry about laxatives that are already on board that patients don't recognize. A common concern for us are agents that or substances that patients may not realize they're ingesting, particularly sorbitol, which is found in a lot of sugar-free products. And so if somebody's gone on a sugar-free diet with a lot of sorbitol, maybe that's an issue for them. Or maybe they have a lactose intolerance, or there's some other issue going on dietary-wise, that there's something in the diet that's affecting that. In addition, you worry about drugs that have a toxic effect that's manifest in toxicity with diarrhea, among other things. And the two agents that fall into that group, in my mind, are colchicine for gout. We'll talk more about that later in the year. In digoxin overdose or digoxin levels that are high, nausea, vomiting is a common presentation for adverse effects. The non-specific antidiarrheal agents are either the opioids or structurally related to opioids, but non-opioids. The opioids can be effective. They will decrease intestinal motility. We typically avoid the opioids, though, unless we've tried non-opioids that don't work, and there's a good reason. And part of that is because of the opioid epidemic we have. And so clinicians really are quite hesitant of using opioids for diarrhea unless nothing else has worked for that patient. Diphenoxylate is a opioid derivative, and so we'd consider diphenoxylate an opioid. It's often in combination with the antimuscarinic atropine, known as Lamodal. Pretty common to see this agent used a decade or two ago, much less commonly used now, but you'll occasionally see it. The go-to non-specific antidiarrheal agent that folks will use is Imodium or loperamide. It's structure related to the opioid meperidine, but it is not does not really not cross the blood-brain barrier, so it's not considered to be an agent that is associated with much opioid abuse or risk. It reduces the volume of discharge from patients with ileostomies if that's a problem for them. It's considered an agent that is not controlled and little likelihood of abuse with its use. Occasionally, you'll see a report here and there that indicates someone's trying to abuse this agent, but really, for the most part, not really considered an abusable agent. Some of the opioid agents that are no longer really very commonly used at all is paregoric, a dilution of opioid and morphine, or opium tincture is another option. But again, these opioids are rarely used. We also have some other non-specific agents. We alluded to the bulk-forming agents like psyllium. If you have someone who has some frequent loose stools that might be amenable to fiber supplementation, like with psyllium, that's sometimes a consideration. And so fiber will actually absorb some of the extra fluid or colonic water and lead to a more consistent stooling. We often will see also, particularly if there's spasms involved in this diarrhea, to use an antimuscarinic or antispasmodic drug. And we saw this with, for example, Lamodal we talked about with the addition of, Lamodal with the addition of atropine as an antimuscarinic to relieve cramping. We sometimes will see other antimuscarinics used if this cramping is a big component of that diarrhea. So let's look at some of the agents we have here. First of all, loperamide, probably the most common agent we'll use is an antidiarrheal. It's a mu receptor agonist that doesn't bind to central nervous system mu receptors, so it doesn't bind to the opioid receptors in the central nervous system. And it's good for mild to moderate diarrhea or adjunct with other therapies. Then there are all of the opioids rarely used. The one I didn't talk about but are listed here, and it's probably important to think about, is bismuth subsolate, or this is also Pepto-Bismol. It's useful for mild to moderate traveler's diarrhea. It binds toxins, and it is moderately effective for diarrhea for patients. And so You want to be sort of aware of that as an option, and patients may have already tried that before they come to you. The concern, though, is that you want to avoid excessive salicylate toxicity with Pepto-Bismol or bismuth subsalicylate, or if they're on high-dose aspirin already, we want to worry about that. It also may affect binding with other drugs, and so you want to see some drug interactions associated with bismuth subsalicylate. There are some other options we have. If someone has a lactose intolerance, we can use lactase, an enzyme that is well tolerated. Folks will take this with their meal. So for lactose intolerance, that's really quite effective. Probiotics are sometimes helpful for preventing antibiotic-associated diarrhea. We sometimes see this used in the management of patients with C. diff, although that's a little more controversial. And we are worried about using probiotics in patients who are immunocompromised. For folks who have certain tumor-related diarrhea, we can sometimes see subcutaneous administration of octreotide, suppressing hormonal release of some of these tumor-secreting diarrhea issues. We don't see it used often, but occasionally you'll do. And then there's an agent we haven't talked about for individuals with short bowel syndrome who are dependent on parenteral support with diarrhea, GLP-2 analog, Gatrex. And again, this is going to be something that's probably only going to be ordered by a gastroenterologist and using a glucagon-like peptide analog. If you've got a patient who has infectious diarrhea, there's a few things to consider. But first of all, we don't want to give an antidiarrheal without addressing the risk for infection. If they've had bacterial or protozoa, they've traveled to a particular area, those are usually self-limiting, and we would use antibiotics if the stool sample suggested that it was Salmonella or Shigella. And traveler's diarrhea, most often that's E. coli lasting a couple of days. If it's severe, we sometimes will use ciprofloxacin or quinolone antibacterial. For mild symptoms, loperamide. But the problem is when you give an antidiarrheal for someone who has an infectious diarrhea, you potentially prolong that diarrhea and prolong the infection because the intent is to expel that. So you want to be aware of that. You want to be particularly good in your history about is this person had a recent travel to an area where infectious diarrhea would be more common, or where there's a question of hygiene. And that could be both out-of-country travel, but it could be in-country travel, particularly if you're in an area that, for example, someone's just recently responded to a natural disaster where septic systems or sewer systems have been compromised in some way, shape, or form. Let's now talk about interabdominal infections or peritonitis, and we consider these whether or not it's primary or secondary. Primary meaning you don't have a focus for the infection. And for primary peritonitis, we are more likely to see this in someone who has chronic cirrhosis with ascites. And we talked briefly about this last week, but there could be other etiologies as well. And in these cases, we're looking at E. coli, Klebsiella, strep pneumonia, and other strep infections as being the more common pathogens involved. For intra-abdominal peritonitis, we would look at whether or not the etiology is from blood spread or lymphatic spread, whether it's transmural. If a woman has an issue for peptic inflammatory disease, whether that's an issue, and whether or not they present with fever, abdominal pain, nausea, vomiting, diarrhea, abdominal tenderness, and if they have ascites, what's the nature of that acidic fluid. For secondary peritonitis, we also look at other etiologies on board, particularly folks who have had an injury to the GI tract, gunshot wound, that kind of thing, peptic ulceration, or appendicitis, or pancreatitis, diverticulitis, or a neoplasm of some sort. We also worry about peritonitis risk for folks who've had peritoneal dialysis. This is probably one of the more common complications for folks who have peritoneal dialysis. Our treatments for peritonitis, depending on what the etiology is, for mild to moderate community-acquired, we might be able to get by with a cephalosporin. There's a couple of choices, and we often will add metronidazole for anaerobe coverage. You could use piperacillin tazobactam or ticarcillin clavulanate. You could use an anaerobe fluoroquinolone. The only one that covers anaerobes is moxifloxacin, or fluoroquinolone plus flagyl. In more severe cases, pip-tazo probably trumps ticarcillin clavulanate, which is rarely used anymore. Or you could use anti-pseudomonal penicillin like ceftazidime or cefepime plus metronidazole for anaerobe coverage. And then you need to evaluate whether or not you need MRSA coverage with vancomycin or not. And typically, you want to continue therapy until you control the source of that, if that's possible. But usually we're looking at a 4 to 7 day duration of therapy. So spontaneous bacterial peritonitis, we briefly alluded to this, particularly in folks who have ascites and cirrhosis. The bacteria we see commonly are gram-negative bacteria, most commonly E. coli and Klebsiella, but particularly in folks who've had any kind of instrumentation done, if they've had peritoneal drainage of some kind for ascites, then you're going to worry about gram-positive as well, and that could be staph or strep. The management typically is going to be, as we alluded to last week, cefotaxime or ceftriaxone is our first choice. Sometimes we use quinolones. We're going to reserve albumin for folks for whom we really need to preserve their renal function and reduce their risk for hepatorenal syndrome. We also look at preventing spontaneous bacterial peritonitis in those folks who are high risk, particularly if they have a variceal bleed and had a prior spontaneous bacterial peritonitis. And in those cases, we may look at a low dose ongoing use of a fluoroquinolone or Bactrim or ceftriaxone. Let's now talk about C. diff, Clostridium difficile, difficult to deal with. We see this as endemic in many healthcare organizations, particularly in hospitals and nursing homes. It's transmitted primarily from the fecal-oral route by spores. Hand washing is the best thing you can do, and the alcohol sanitizers will not kill C. diff spores. And so if you're in an area where C. diff is endemic, you need soap and water hand washing, not the alcohol sanitizer hand washing. Risk factors clearly are antibiotic use in conjunction with a patient who's been exposed to those spores, hospitalization particularly, or a setting where C. diff is common. It will often present with watery diarrhea, abdominal pain, and that diarrhea often has a certain odor to it, and the patients in healthcare will be able to sort of say, hey, this kind of is indicative of C. diff. You can't necessarily say that, but it's common in more fulminant cases of C. diff. And in the last decade or so, there's this newer, more serious strain with more enterotoxins associated with it. This B1 NAP1 strain is a concern for us.
Treatment guidelines for C. diff infection have been updated over the last few years. The latest versions that is available from the Infectious Disease Society of America is listed here. This is as of mid-late 2021. And what you'll see is a first-line therapy, preferred therapy is fidaxomicin, but the alternative is oral vancomycin, which is considered still, particularly for initial C. diff infections, as an acceptable alternative. Fidaxomicin, while it's probably the most effective, the issue with fidaxomicin is that it's very expensive. As you can see here, as of September 2022, using a discounted platform, GoodRx, a typical course, a 10-day course, will cost about $4,600. And that's quite expensive. So I think in practice, you'll still see clinicians primarily start with oral vancomycin, which is much, much less expensive, and then consider fidaxomicin more likely for recurrent infections and or refractory cases refractory to oral vancomycin.
And here are some of the drugs we alluded to. Again, most of these are upper GI drugs. Okay, very good.